do some motions like this through the scapula. And so I think this is an attitude of mine, because this doesn't present in a book, and I'm not putting it forward as being original to me. I'm just sort of saying, I think if we just think about the biomechanics and how we could do it, we can all write our own books and run courses. And you teach this, and this is another thing. So now we've got another course that can be taught. God forbid. Okay, for doing these. So if you could not so much just learn, where to stand and how you hold your tongue and what you do with your foot and all of this stuff, but you try and think, how can I get hold of this in a comfortable way, and how can I move this about in a reasonable way? I think that that would be much more advantageous to you. Now, if we go to the AC joint, can you lay on your stomach, Anne? I'll take this side. I'm only going to illustrate these because, a lot of these little bits and pieces are kind of quite important now. We come round onto the AC joint. I'll pick up where it is. This goes out onto the acromion now, and I can come onto the back part quite easily of the sternum now, because it's of the clavicle now, because it's easy to feel, and I can move it forward like this and get these glides, or hold it here and move it backwards. But the forward movement is quite easy to do here. The backward movement is not so efficient, so I roll her on her back to do the backward movement. And now I'm going to do this side, of course, and I'm moving the clavicle, yes, and I'm fixing the acromion. And now I can hold on this side, and I can do the backward motion here, or I could hold the clavicle and actually move the acromion. So these are things, I think, to not try and just learn lots of stuff, but there are principles such as distraction, which we always try to do to joints, and then we can sort of put it into operation around here. So when we look at this plan of looking at the girdle, and I've really not done justice to this in terms of all of that Cliff shows about this, but in actual fact we've done it by a different route. We've come at this from the end rather than starting and then having to learn all of the individual techniques to move this. We learned those techniques, so this is basically just a matter of just going through this little plan, and that's what I'd like you to do for 10 minutes, would you? Because it's so important to look at the manubrium, the first rib, the thoracic spine and the clavicle, and Anne and myself will be around, and if you're having problems or there is a thing to fix, let's fix it.
Could you write down those two, the Overton article and the tunnel?
See? Bam, bam. Yeah. Like Dr. says, but I really don't like them very strong. I don't like the dry ones, they're very dark. I love real random.
Now, let's just go a slight step further. And we're not going to be able to look at the significance of this particularly, only in terms of sort of asking you to perhaps think about this over the next while. I haven't done sufficient work in this since Cliff Fowler introduced me to it to fully be able to manipulate the facts quick enough that's coming to me when I'm testing this. And so I want to really just introduce you to sort of some stuff that I think is very important as far as combinations of motions that occur in the shoulder and the restraint factors, and how these restraints are being brought in all the time in combination. And I think this is kind of an interesting thing that's been very well documented by the Houston Clinic, who did a whole series of stresses on a dissected shoulder with strain gauges in the ligaments, and pointing out what the percentage of ligamentous strain is at different parts of the shoulder. And it certainly makes us wonder a little bit about some of the tests that we've done in the past to test the shoulder stability. Now, when we think about the shoulder, and we're examining the shoulder, and we go through the movement diagram that Earl developed, or you go through your sequential list, if you like that, of how you examine, there are two things that we occasionally come across, which is we come across the impingement syndrome, or we come across strange little shunts and all this kind of stuff as a person's reaching up to the end, or they produce a kind of a strange motion up here. And impingement can take the form of two things. One is we can have impingement with an arc. So we know, and this is a nicer and a truer thing, I think, that as we go up through a movement, that we can have the painful joint or the painful structure nipping, and then suddenly we go past that and it goes further up. And this would be what Cyriax classified as a painful arc. No pain, pain, no pain, as the movement continued. We can have the situation where we have full or less than full movement, and as we go up we wonder, is this a kind of a localized ligamentous thing as we come up into this restricted range, or are we nipping something as we go right to the end and the body is basically not liking this? Well, we can look at that then in relation to Cyriax's finding A and finding B, which is the restriction and the passive movement in the same direction, or is it that the isometric activity in one direction and the stretch in the other are painful, to try and work out whether it's a contractile or a non-contractile structure. I mean, that sort of comes to mind. Now, if we look in the shoulder itself, there are kind of a number of factors which are a weakness. One is the whole development of the suprahumeral space. It's not great, is it? We've got a lot of structures within a space which are materially affected by a whole host of things. So that if I take my arm up to the side, I am expecting my shoulder joint, that is the head of the humerus, to sort of descend into the wide pear-shaped part of the glenoid here, and also to rotate itself like that. And if I've got a dysfunction in this motion, so that as I go up into elevation it rolls like this, that's going to threaten all of those structures in the suprahumeral space. And unfortunately, the suprahumeral space, if we can kind of see it on this colored picture, this is when I thought I'd go into Technicolor, and you can't see it at all, but never mind. When we go into this area here and we see the synovial capsule coming around with the extended part onto the head of the biceps here, and then above that we have got the ligaments and the supraspinatus muscle with the coracohumeral ligament, of course, the posterior part of which merges with the supraspinatus, and the anterior part which comes in and then becomes the transverse ligament across the lesser tubercle here. And then above that, of course, and they're forming the floor of the subdeltoid or subacromial bursa, and then we've got this coracoacromial ligament here. And so that if anything happens to the rotation elements of the shoulder and its ability to descend, or perhaps even the ability of this clavicle to rotate, it's going to make a difference in this suprahumeral space. And this can give us impingement syndromes. And you remember that one of the most common findings is you come up into, say, an abducted position and that hurts. And you make them do exactly the same contraction, but you pull down a little bit and that doesn't hurt. In other words, we're preventing the upward riding of the shoulder joint at that point. And that makes a difference. So one of the major things that we have got to do when we're ever trying to restore shoulder joint movement, and many of these things we can actually make up and construct very nice kind of techniques for this, is to make sure that as the shoulder abducts that it starts to descend. And I think that that is a technique, a sort of combined technique that we should perhaps investigate at this time. But if we think about that suprahumeral space and what can go wrong, and look at it from the lateral side here, okay, with the coracoacromial ligament and all that other stuff under here, one of the things that we have to think about very much, and Dave sort of reminded me just to sort of speak of this by looking at him. He's a sort of a swimmer, and swimmers have a lot of folklore about how mobile the shoulder should be, and they got them very immobile sometimes, and they get sort of subluxations, so that we get shunts and shifts, and this is not very stable in its joint, and this is constantly going up into here, and with the movements that they're doing coming back here, they are wringing the supraspinatus, and if this is riding up, the supraspinatus being wrung out by the movement, it's also being compressed, and the blood supply to this tendon, particularly the supraspinatus, is seriously attenuated by the movements. And then of course we were talking about this the other night, then we've got a few years ago the thing that the only way that you could ever succeed in swimming is more and more and more laps. So you got people that were totally wearing themselves out, wrecking their shoulder. They were all going through these, buddy exercise, pulling up and pulling up like this, so they completely wrecked the anterior stability of the shoulder joint. And so here we had some sports-induced problems through the mythology of the whole sort of training program. And all sports have this, no question. And it just doesn't fit in. And so this business of the suprahumeral space tendinitis is a really one that we should address. And I think on this kind of course, it's a shame that we kind of don't have a little bit more time on here, but one of the things that we started with and then we kind of didn't develop it is to look at all these causes of pain here. And one of the things that I think is so important in this area is to consider some of the work of Chan Gun, who has developed a kind of a model of degenerative change that goes on in the collagen as a result of this being in a state of kind of like hypertonus or part of the facilitated segment. And that in the neck it's very important to try and fix this because of the consequences of muscle spasm and also collagen degradation that's going on in the target tissues of what those particular nerves go to. And if we combine that then with a problem of motion here, we can see that this whole thing builds up to a point where repetitive strain injuries don't recover themselves. Now, just let me very briefly go over this stuff that Cliff Fowler sort of found, and just have a look here. You see the pictures of the coracohumeral ligament here, and we've sort of described from Kapanji's diagrams here an anterior or a medial and a posterior or a lateral band, okay? And we've kind of accepted this. What was the test? Well, there were two groups of tests that were done here. There were the kind of simple tests that I used to do. The simple guys. All right? So this isn't going to be good enough for you, but this was kind of good enough for me. All right? I used to sort of feel the ability of the head of the humerus to separate like this at the side of the body like this. And I knew very well that under those circumstances, the coracohumeral ligament had to be under a relative degree of tension because it's a suspensory ligament. Now, if I went into just a few degrees of abduction, so what I thought, a few degrees of abduction, I should be able to separate the joint more because the coracohumeral ligament has had some of its stress taken out of it, and I'm not at this stage put on sufficient abduction to put tension on the lower part of the capsule. So I'd expect to find more movement there. Now, if that movement and that movement were the same, in other words, I felt that that's the normal, but when I go back to this, which I'd expect none, I can still pull it out. To me, that was some indication that the coracohumeral ligament had been upset. No, not isolating bands. And I'm going to really challenge this whole business about bands in a minute. Okay. Now, then we sort of tried the band business, and we thought the anterior would be more put under tension if we go into an extension position. And indeed it is. There's no question. And I can come here and then I can pull out to the side and see if that movement hasn't really tightened up. It's still, I can pull it out, which I shouldn't be able to do. And then we went to the posterior band and we pushed backwards, Okay, so we came up into flexion, and then we tried to sort of push this further away from its attachment point on the coracoid, and this seemed to be good. We looked at models, and we got these little bones with all the things on, and we kind of worked away there, and we did all this. And we came up with what Kapanji said, and we thought it was all good, and we all did this. The thing is, what do we do if we find one of these? What difference does it make? Does anybody operate? God, they don't operate on what we say unless there's major instability here. And so, it's really very interesting to know, what do we do with this information when we've got it? We know we don't mobilize it, but how do we kind of stabilize it, and what do we do about it? The other thing was to look at the glenohumeral ligaments, and this is kind of interesting because one of the better books on anatomy in Britain, or like a practical book on anatomy, was written by Last. And Last's anatomy book was always the one that was used by the surgeons, because Last was the head examiner for the Royal College of Surgeons, so you better know his points, okay? And this is a picture from Kapanji, who's got the 3 bands, but why I mentioned Last says these are so insignificant, the glenohumeral ligaments, that they can be ignored, and that's all he says. 2 lines on this. Well, some recent work has come out which tends to refute this particular idea. Here's a dissection looking at the lateral side of the shoulder joint, where the shoulder itself, the glenoid, is there, and the head of the humerus has been removed. And what we see is that the glenohumeral ligament is not a little indeterminate kind of structure. I mean, I don't know how Last came up with this. I mean, he draws well, he writes well, he's seen presumably lots of stuff, and yet what he's got is it's insignificant. Look at this that's been done from very recent dissections, and what do we see? That the superior glenohumeral, the middle glenohumeral, and the inferior band of the glenohumeral ligament are very big structures. And that the glenohumeral, or this posterior, inferior band, has got 2 very distinct sections, an anterior and a posterior. And in many cases, we've got this, which is an axillary pouch between. We always knew that there was an axillary pouch, but this is, in some cases, almost like a complete rim right the way around, with quite large structures here. So we kind of look at that, and we take the next picture, and we see this, which is that the numbers on there represent the 11 dissections that these were taken from, and what they noticed was that the inferior band, which is so important and is going to have increasing importance because all of the movements where dislocations take place tend to tighten up the inferior bands. So the inferior band is going to be a major restraint factor for dislocations. So this is obviously a very important structure, and what we see is on all of the ones round to dissection 11, that you can see from 2 to 7 to down to there, this is like between 2 o'clock and 4 o'clock, but the posterior band is like between 9 o'clock and 7 o'clock, like this, if we're looking in on this side here. The other side, of course, would be reversed. But the anterior is slightly higher than the posterior. And the posterior is sort of the lower quadrant here. These are like the middle quadrant, with the, by far and away the biggest group at the central part of the anterior and towards the top of the posterior. That's where they're originating and sweeping down. So, we look at this. Here's what was done. They took a dissection like this, and took these inferior bands and sort of opened the capsule out, and we can see that this is quite a distinct lining of, or orientation of collagen. So we'll look at this now, which is the next picture, and what we can see is a number of really interesting things. That the middle part, the axillary pouch as it's called, isn't just a sort of undifferentiated mass. It's really quite well developed, when we can see the ends of the fibers here. The lower part of the pouch, the fibers, we're looking at the length end on of this, whereas the posterior band that we've got here, we can see is a very well differentiated structure with the collagen tissue very well arranged. And here we've got a sort of a rather bigger microscopic section of this going from the anterior capsule, and we can see this differential arrangement of the capsule with some fibers that we can see end on, some fibers that we can see sideways on. So this arrangement of the capsule is really very important. Now then, to look at the bands themselves, and this is the inferior bands, both the posterior and anterior. There seems to be two groups of arrangement. Either we can have like a dependent pouch here with the anterior and posterior bands, or we can have almost like a cuff arrangement all the way around, like that. Now then, if we look at this band, remarkable, because these have an incredible capacity, evidently, for opening themselves out. So here we see the picture, and we can see that as the patient goes into a position like this, they're going to tighten the posterior inferior band, and as they come into this position like this, they're going to tighten the anterior band. So when we're talking about the motions that occur in the shoulder joint itself, we know that as we come more and more into abduction, the restraint factors get lower down in the joint, and we've got some huge restraints now doing this. As we go into lateral rotation, that's going to tighten more the anterior group of structures. And as we go into medial rotation, it's going to tighten the posterior structures. This is sort of what we've known. And the greater we are into abduction or adduction, the more it will be posterior inferior or anterior inferior. These are sort of interesting little things. Now, when we to go back to last, because this is an interesting thing, and then I want to sort of change onto a slightly different tack, a different article altogether. This was from the Houston Clinic, and this received all kinds of accolades, this particular article, because this was some very nice dissection. It has incredible importance in terms of restoration, surgical restoration of the shoulder joint. Now, one of the things of the lateral rotation, which is perhaps interesting or good to trot out at examinations, of course, is that if you come into an abducted position, why do we laterally rotate? We normally talk about steering the greater tubercle around the acromioclavicular ligament. Okay? What LAST talks about is that as you go into abduction here, you've run out of joint space or of joint surface. So as you externally rotate, you've got all of that joint surface, and if you look at it, it's true, now available for movement again. Which means that on a sort of hemispherical head, we can kind of doubly use the surfaces. Here's another little thing that LAST gave, which might be of importance to us, is that when we look at the synovial covering of the long head of biceps, in this position, it's not very revealed. What we have to do to get it to move out and to slide out a little bit here is to go into an abducted position. So if we're trying to insinate that or give deep transverse frictions, perhaps we're not getting anything when we're here, because only a little tiny bit is extending from the tip of the shoulder, and then we've got the transverse ligament across here, so perhaps there is very little of it accessible. And so to get it out, we need to come into an abducted position. Okay. Now, what does all this mean to us? Well, another article that Cliff gave, which I can look up, just a beautiful article, and the name of the person that did this and the workers kind of just has gone from me just at the moment. But they had a machine that they put in a dissected part and tried to put different motions on the shoulder joint and look at how these motions are absorbed. And they produced some very nice little diagrams like this, which I meant to sort of color up so to be a little bit more easy, to show which structures take the majority of the action. And as you see here, that if we come up into a flexed position, what we've got here is that the majority of the restraints of flexion are in the anterior coracohumeral ligament. We used to have the posterior, remember? And also the middle posterior capsule. That's what's taking the vast majority of those actions here. If we take the abducted position, we won't have time to sort of study these to any great degree, but if we have the abducted position, we can see that if I just draw this down to the bottom, no, just a little bit too big there to go on. Okay, from the thing here, that if we go into the abducted position, this is one of the few cases where there is a little bit more activity in the posterior coracohumeral ligament. The vast majority of the restraint, though, as we see, is in the posterior inferior part of the capsule. So the whole thing of this is Cliff looked at this and he's now developed a sort of a new protocol of examination to try and look at the combinations of this and see if we can change them. So from all these figures, we put them on this, and put them on this thing here, like this. Okay, so that we've got the anterior coracohumeral, posterior coracohumeral coming right the way across. And what do we see? That if we just take lateral rotation, for example, and stress it passively, as was done on this machine, and whether all that can be extrapolated, of course, exactly into the living being, I don't know. But if we sort of come along here, we see that the anterior coracohumeral ligament takes 23% of the strain, the posterior 9%, 42% in the superior glenohumeral, and the middle 26% in this way here. And that if we then come into medial rotation, very little of it is taken, and none of it is taken in the coracohumeral, but it's all going into the superior, and even more interesting, into the inferior parts of the of the posterior part of the capsule here. So I think what we've got to ask ourselves, and all I'm putting this up for, is to say, are all these tests that we've done in the past, that we've come up with all these findings, are they all that valid? And I think we've got to constantly challenge ourselves with this. There's another thing that they came out with, and this perhaps is going to have significance, as to, say, Dr. Cyriax's concept of capsular patterns. Perhaps we've got a variety of capsular patterns in the shoulder joint. Look at this one. See how nice that is? I've got this special thing here. I was going to put all my foils in this special little thing. I'm afraid it's still in its package at home. But look at that. That's nice. I'm going to do that. Okay, that if we get this little device and go up into flexion, simultaneously to doing flexion, we produced external rotation and abduction in the humerus. And so when we go through flexion, we've got to look at the restraint factors that also stop these. So perhaps we're going to be able to say that we've got a capsular pattern where abduction or external rotation isn't the most important movement. Perhaps flexion could be. And the flexion kind of capsular pattern has so many degrees of restriction of external rotation and so many degrees of restriction of adduction. But the flexion is the worst, which you wouldn't expect from Cyriax's kind of capsular pattern movements. You wouldn't even test it, for one thing. And so when we look at this kind of picture, it shows us that all kinds of restraints occur, and that if any of these movements are lost when we do any of the other movements, the restraint mechanism is going to be disordered. So it's very important for us to sort of examine and try and get back some of these motions as far as all of this is concerned, and not just go with, you know, a single planar movement here, because these are an important kind of consideration. Now, I haven't really got much more time sort of to